Here we are. Welcome to London, guys. Welcome to London.
Thank you, Lorenzo. It's a pleasure to be here. Thanks for inviting me. That's the story of one of those patients I'm sure everyone has, because this is one of those patients you remember, either because they keep coming back over time, and also because sometimes strange things happen, especially when you're young and not that experienced. This story kind of begins in 2018, when I was a consultant since a few weeks, and it's late in the afternoon, and I had on the table this lady with the occlusion of the femoral segment. She, as you can see, she's moving all the way around. I'm not really able to hold them still. I'm not really able to obtain a good quality images. I'm not really sure how to deal with this situation. The thing that comes into my mind is just go into the procedure as fast as you can and try to finish early. And so I managed to find my way towards the patent popliteal artery. I expanded the occlusion, not that I should have, because the patient was complaining really bad during balloon expansion, and I thought, whatever, I go on with the superior stent, and I deployed it. But what happened was that I ended up having a really bad stenosis at the very proximal end of the stent, and the nose cone of the delivery system remained stuck into that stenosis. I wasn't able to retrieve it, and during my attempts, it broke. And I wasn't able, again, to make nothing because filters or whatever, I wasn't able to pass through this plastic piece I left there, so the patient received a good old-fashioned femoral popliteal bypass using the great saphenous vein of the contralateral leg, since she had varicose vein on the right side.
Quick question. How much of the stent did you deploy already?
Pretty much all the stent. You see, that's the proximal portion. During the last deployment...
the last one, okay.
Yes, this is completely deployed, as you can see there. Anyway, symptoms disappeared. The patient continued smoking, and she came back in 2020, and I treated her with a left on the contralateral leg, common femoral artery endarterectomy and patch. And after a few more months, I performed a quite challenging revascularization again on the left leg, which could have been also the focus of this case-based presentation, but it's not. I'm just going quick through this to show the final result, and then I ended up deploying a superior stent quite deep into the peroneal. And that's the result, quite good. Again, symptom resolved, and the patient was discharged after a few days with a digital amputation healing. Finally, a couple of months ago, she came back because she had once again CLTI on her right leg, where I performed the femoral popliteal bypass. And the duplex scan detected a high-resistant flow into the patent venous bypass. So what we suspected was a failing graft, maybe a stenosis of the distal anastomosis at the time. Yeah.
I have a question for you. Did you leave the plastic in, or did you remove it while doing the bypass?
No, I leave it there. I just performed my anastomosis proximally and distally. It thrombosed, and no problem.
You feel okay by leaving plastic there?
Yes, because I'm not working in the UK, so I didn't have to report nothing, and that's it.
That's it.
So, at the time, the patient was 85, a couple of months ago, diabetes, hypertension, coronary artery disease, COPD, and still smoking. And she had a rest pain and a small infected digital ulcer. So that's the diagnostic angiography I performed, puncturing the left common femoral artery where the patch was. And as you see, the diagnosis was actually wrong because I didn't found a stenosis at the distal anastomosis, and that's the magic of a vein bypass. Actually, she lost every kind of outflow vessel there. You see we had just a peroneal over there, but no continue flow from the bypass towards the BTK vessels. And as you can see from these images, the patient was still moving all the way around, for those who remember her, like Charlie from Street 5 there. So I saw these images. I thought that this would have been an easy peasy procedure, just perform DCB on the distal anastomosis and whatever. So looking at this and knowing the patient, first poll of the presentation is how would you approach this case? You would continue your approach from the contralateral side where I puncture the patch. You would go antegrade, maybe puncturing the bypass, or you would go for another access, maybe an upper access. Flex on. Antegrade. And
Gioele, can I just ask you, was this an in situ bypass or was it an anatomical?
Inverted.
Inverted?
Yeah.
And it's tunneling anatomical position,
yeah,
or subcutaneous?
It is anatomical position.
Okay.
No one thinks about arterial access there. Those could be an option.
Yes, you could have tried, of course, but as
you were seeing some vessel that the dorsal species was there.
The peroneal was there.
Only the peroneal.
Just peroneal.
I see some anterior. What's a low bifurcation of the peroneal into the anterior tibial?
You cannot say that because the patient was moving all the way around and the quality of the images was not that good. That's why I actually decided to remove my full-frame sheet from the left and reschedule the procedure from the day after when I have anesthesiology available, and under general anesthesia finally perform a small incision in the thigh, isolate the bypass and puncture the bypass in an antegrade fashion. So that's my first approach. I tried to recanalize the occlusion with a workhorse guide wire, 014 common DS. But after a few attempts, it appeared clear then that I was not able to find my way towards the peroneal, neither trying to remain intraluminally or pushing my guide wire in the subintimal space. So the first strategy I implied was guide wire escalation. I switched my guide wire for an Albert 014. And while it was nicely advancing the tip of the wire, when I shoot an angel from the introducer sheet, it appeared clear once again that I'm not going in the right direction, as you see in the right-hand side of the slide. So when things get tough, maybe it is time to look at them from a different perspective, and then shooting a distal angio, and once magnified, and once the patient was standing still under general anesthesia, I decided that the distal peroneal was not that bad to try to obtain a retrograde access. And that's what I did, using 21 gauge needle, 018 Navicross, and a V18 guide wire. I tried to obtain my way towards the P3 or tibioperoneal trunk where I was stuck with my antegrade access. But you can see that I struggled in advancing my V18 guide wire, so I tried to support the guide wire, but the catheter is not passing beyond tight stenosis. I detected shooting an angio from there in the peroneal, as you can see also here, while after pushing, while retrieving the catheter, I'm pretty much pulling the entire artery. So that's another turning point here. How would you proceed? So you're not really able to advance your guide wire from below, and you're not really able to support it with your microcatheter. Balloon for retrograde to get rid of the stenosis could be an option. Of course, I decided, since I already had my Albert 014 on the table, and I tried to use in an antegrade fashion to give it a shot using, so with guide escalation, using that guide wire. And I managed to reach the antegrade access, as you see. And therefore, I removed the balloon I was using to support the guide wire from above, advance the catheter from above, and try to establish my true and true, entering the catheter lumen from below. But as you can see, I'm probably not in the same dissection plane from below and from above, so that's where things, I prepare myself for the hard work, and I advanced the balloon from the antegrade access 4x60, and I tried my best to imply in the correct way the cart technique, so inflating balloon and pushing the guide wire from below. And
wait, just a second. You remember what yesterday Edward Choke said? X marks the spot.
Yes.
Remember? I think it was amazing presentation, and you see here the guide wires are crossing.
Exactly.
It was worth trying to exchange the projection to see if this is really the little flap where the two guide wires could. Before, I mean, CART is great, but I mean, these things really opened my mind to a different view.
Absolutely, absolutely agree. And in fact, that's the first segment where I tried the cart. I was unsuccessful once again, so I pretty much ballooned all the tibioperoneal trunk and the distal popliteal to try to enter in the same dissection plane. And once again, I struggled in what seemed pretty much the end of the procedure. I couldn't reach I wasn't successful in establishing this true and true.
So guys, can I ask you, is this a good scenario for your repop?
Yes, definitely.
Do you think so? Can you explain to the audience?
Thanos, also you published with me on the repop technique. No, you do, come on.
You could, yes. I think it's sensible here if you cannot cross to get the outback from above or below and puncture the balloon and connect the two channels. I think it will save you time and potentially radiation and maybe not money, but definitely time and radiation.
Contrast.
That's a good point, of course, but when I advanced the balloon, I thought that I'm gonna be successful at the first attempt, so this was not. So looking in this perspective, that would have been an option, of course. So when never give up, of course, also according to the beautiful paper from Korosoglu and other friends, you should keep trying, especially where you see the guide wires running in a parallel path. And so I advanced once again the catheter from above and finally managed to obtain my true and true after really struggling in this. And then 3x120 jade was advanced in the occlusion. Occlusion was dilated and prepared, and that's the result obtained. Pretty bad.
Of course, I mean, I was not expecting a good result.
Of course.
You know, it's bloody obvious. You know, if it was an easy lesion, you wouldn't struggle that much.
So that's it, and okay, I decided let's try with a larger balloon, low inflation and prolonged. 5 minutes at that level and 5 minutes at a lower level over there, and the result was slightly improved.
Sorry, there's 5 millimeters also in the peroneal?
Probably not really into the origin of the peroneal, just at the distal tibioperoneal trunk, as far as I could detect where the bifurcation was. So that's the result. Little improvement, but in my mind, you still have a dissection here. You see how dark this portion is. You see you have a sign minus image on the right-hand side of the slide. So what would you do? This result.
I also think that an IVUS here wouldn't be a bad idea. If you have IVUS, I think it's just to understand what's going on. Also with the popliteal, I see a big flap above. So
scaffold, and that's what I did. Yeah. Agree, of course.
Luckily.
Luckily. So I decided to implant a superior stent, but I had also to think about what size, because you see, from the origin of the peroneal, using a 60 millimeter stent, I would probably have landed inside the bypass proximally. So a 4.5 would have been small proximally, and a 5.5 would have been large distally. Anyway, I decided to go with the 5.5, trying to compress the stent as much as I could. This is not working.
Can I ask a stupid question in the audience? Who is using 4.5 superas?
4.5.
4.5 in any situation. Let me put it that way. Is anyone using a 4.5 supera?
It is not working.
I don't. I think it's awful, personally, because if it blocks, and it usually blocks, then it never opens up. But is anyone using a 4.5, and why? No one. Okay, great. I'm happy with that.
That was also my comment on this. There are also some other scaffolds than superas.
That was going to be my next comment.
This was for me definitely not an indication for a supera here. There are nice scaffolds with low chronic outward force, like a pulsar or an absolute, whatever, low chronic outward force. So with one size that you can overcome this anatomical mismatch between your distal area and the proximal area. So if you implant the 5 millimeter stent over there with these low cuff stents, so you're not going to exaggerate distally in terms of chronic outward force, and proximally you still have a nice wall positioning. So I would rather go for a scaffold like this.
I would be a bit more provocative. I don't disagree with you, but I would have used a 4 millimeter Zion stent distally, maybe.
Can I have my presentation back?
And then use a 5.5 super above that.
It's okay, you can say whatever you want. You can
Yes.
say,
Indeed, this is the
My point was that the 4.5 Supera, because you've mentioned it,
Yeah.
it's a wrong choice, and I'm sorry that I'm that blank.
No, I agree, absolutely.
So we are in the proximal part of the below the knee segment.
Yeah.
And I think we know properly that drug-eluting stents are best devices in this portion. First, and a second question also to you perhaps. What about spot stentings, tuck stents? Are they off or because we don't hear anything about them the last
well, once
years?
we did one, yeah. The thing is, like, I think personally I can answer that. The lesion is too long. It's all dissected, so you can't. Spot stenting is good when you have a very focal flap.
But
this is
even too long for a science?
size is 38. You can put 2. I mean,
you need
what-
to implant all 6 stents without good results.
6.
Because it's a 0.7 centimeter for each stent. I think that the lesion is long more than 5 centimeters,
Yeah.
correct?
Yeah, more or less 4 centimeters.
4
Yeah.
or 5 centimeters.
There is a poor man's supera, that's how I call it.
Can I have my presentation back in the meanwhile?
I think that's right.
Yeah.
Poor man's supera from Balton, it's called Jaguar. It's a woven stent. And here it was almost 6 millimeter above and 4 something below. And you can put a 6 by 40 and it works in a 4 millimeter vessel, it works. I mean, so there's a 2 millimeter span of expansion, it just lengthens. So here it would have started as a 4 and would have ended up as a 6. So probably you would have ended up perfectly with it. And you can also telescopate it and shorten it if you need to. So that's from my personal experience. When you don't have...
Because I mean, sometimes it happens to me that I deploy a Supera and X-Science. And actually, this was at the beginning I was deploying X-Science, flare it and put the Supera on. Now I changed my algorithm. I put the Supera first and then I opened X-Science into the Supera. This also could be, because it's balloon mounted. Don't you like it, Kun?
No, no, and I definitely not recommend it because myself, but also Andre Schmidt, I discussed with him, we have very bad experiences with this. The Supera has such an aggressive opening force that it can really crush your science, your balloon expandable. And also it is mimetic, so it is moving physically, let's say, and it can really crush also in a longitudinal axis your balloon expandable stent.
Wait a second, but if I put a supera and then I flare inside the supera, it excians, you don't like it too?
Well, even like we call it, the vascular mimetic implant. So some parts of the supera with moving your leg and whatever are changing and are having an influence. I have 2 cases where I did exactly the same. It was in an anterior tibial where I treated with a balloon expandable drug-eluting dedicated below the knee stent and then extending all the way up to the P3 segment with the supera. And at the end, my drug-eluting balloon expandable stent was crushed and occluded.
Renzo, at the end of the discussion, I have understand that maybe we don't have the right stent for this situation because
sure.
we need only to solve the dissection, but we must avoid the problem of the stent in the below the knee segment, and so.
Just a couple quick comments. Very interesting case. Tells a lot. Shows some things we know very well, some we don't. But just a couple quick comments. One is that when I get a case like this with a patent bypass and no runoff, and I'm not sure what to do, that's the one unusual time when I'll go for catheter lysis. I mean, I'm not a big lysis person. I like to do everything on the spot, on the day, on the table. You ultimately decided you need time to think, maybe next day, put her to sleep. The other is this is a great case to tell the power of vascular endothelium, because that bypass has no branches. So there's only one RBC going through. It's a standing column, but it didn't thrombose, but it's also an emergency. I mean, you can't do anything, but you can't let her out of the hospital with that anatomy. And so the other thing then is that once you decide to puncture the graft, you can't go away without creating outflow, because the graft's going to thrombose if you're unsuccessful, which I'm sure you knew when you did that. You're a surgeon, you see that. And then the last thing is I would put tacks here. I use a lot of tacks. You put them at spaces so you can do a longer segment. They're short, but you can leave little spaces. You can also, a lot of times with IVUS, tell where is really the lesion here, and it may not be as long as what you think, the actual dissection.
But would you put tack because of the thickness of the struts? Or why would you put stack? It's because he mentioned this kind of biotronic, which is like almost invisible stent. Would you go for, I think I'm more with Kuhn with this.
The thing I like about TAC is the minimal amount of metal and the minimal amount of implant. I mean, you know this is going to go down. It's small caliber, it's BTK, it's a flexible artery, and she's going to keep smoking. So you should be on vacation when she comes back. So then the partner tells you how horrible it was.
Anyone in the house with experience with the micro mesh, micro stent, the mini supera at this location?
Yeah, but the mismatch is a big issue because here you want to land in the perineum.
I mean, we can agree that we do not have a consensus regarding this kind of treatment, and especially the device, which device to use in this situation. Anyway, that was the result, which is not that bad. So I decided to just advance the same jade 3x120 I used to dilate the occlusion across the distal puncture site. And you see the control after 5 minutes and inflation, and also the distal perfusion of the foot is not that bad. So I'm pretty happy with the results. But thinking about what so this is not working, I don't know why. Anyway, I've seen something at the distal edge of the stent, and at the first glance I thought this was probably a residual dissection, but looking back at it, this was probably a calcified plaque right distally to the distal landing zone of my superior stent, and this was probably this is not working. I don't know why. Anyway, I decided to position an angulite stent in here, 3 by 39.
Angiolet is like a drug-eluting.
Drug-eluting stent, 3 by 39, and this was just since I consider I already landed into the peroneal. I want to maintain the patency of this vessel as much as I can to keep the digital amputation I'm going to perform on this patient healing, and I'm so sorry. I could see this on the computer.
Just a quick question. Green flag, who would put a stent? Red flag, who would never put a stent there in this scenario? Come on. Okay. No stent. Why no stent? Why would you put a stent here?
Well, I think I would be very happy that with the results I have so far, and on this angio, I doubt whether it's flow limiting, and then I think just leave it like this, see how it goes, and follow up first.
Ryan, why would you put a stent?
I'd stent it because I think what's above that lesion is too precious to leave.
Yeah.
Exactly as Peter said, this is a precious bypass with a vein that you only get one use for, so make sure it looks perfect.
That was my thought, actually. So you cannot see the image, but it improved slightly, and the patient underwent a digital amputation and discharge after a few days, and it's doing fine.
Okay. I think it's a great case because especially when we pass from the BTK to the popliteal is always a drama, and very well done and good reflection also. Thank you so much, Gioele. Thank you.